Good evening, everybody. Thank you for joining us for this evening's webinar. We're really pleased to have special guest Dr Ian Horsley presenting this evening, and we'll be talking about return to play considerations for the sporting shoulder. Before we do get going, just a little bit of housekeeping from myself. Please feel free to introduce yourself in the chat box. It's always great to see who we've got with us, where in the world you're from, what profession you're from, so please do let us know. We'll send out certificates of attendance to you all this evening for all of you that are joining us live, and we'll send out a link to the recording of the presentation for this evening as well. Please bear with us. We'll get those to you within 24 to 48 hours. In terms of the questions that you might have this evening, you'll see in your menus down at the bottom that little Q&A box. If you could post your questions in there, that keeps them all nice and organised for us. Please don't post them in the chat. And before you do post your question, just have a quick read of what's already been asked, because you can upvote the existing questions, and that just helps us not to duplicate them. When we do come to do the questions, we'll take them in popular order. So please post them as we go along, and it gives people the chance to review those and upvote. A little bit about BASRAT, just before I hand over to Andrew. We're the professional association and regulator for sport rehabilitators, and since March 2020 now, we've been running these webinars on a regular basis to bring everybody some varied CPD topics. You can support our work by becoming an associate member. You can see the benefits on screen there. It's £5 a month, and there'll be a link in the email after this event if you'd like to consider doing that. I'll bring in my colleague Andrew, and then we can get this webinar underway.
Thanks, Ollie. Hi, everyone. Thanks very much for joining. Just a bit of a brief introduction to Steriplast Healthcare, the company that I work for. So we're a medical supplier with over 25 years experience in the supply of medical and emergency and first aid equipment across 7 different sectors. I lead on our work in sport, and we're really pleased to be working with a whole range of different sports teams, organisations, and partners involved in that. We've recently launched a new range of online sports taping and kinesiology taping courses. There's a link there, so if anyone's interested in that, please do have a look. Have a look at our Sterasport website for any of the other news and events that we've got coming up too. Ollie, if you could just move it on, please. So the Injury Rehab Network we launched in 2019. As a Manchester-based company, we were keen to support some of the partners and organisations that are based in the northwest of England, and we ran a series of face-to-face events that were really successful. And with lockdown, as Ollie said, we've been really pleased to work in partnership with BASRAT to bring the events online, and we've had some excellent guest speakers who were really grateful to giving up the time. And as Ollie said, it's kind of a platform for people to learn from experts, collaborate, share ideas, and we've had some really good feedback. Please do let us know if you have any suggestions or ideas for future topics or guest speakers. We're always keen to develop and improve the programme. We are hoping to bring some more face-to-face events to you in the near future, so watch this space for that. If you'd like to, we're supporting the Running Bee Foundation, which again is a Manchester-based charity, and they support sort of healthy and active causes in the northwest. So please do donate. These events are free for people to attend, and we'd really encourage you to support that and to sort of support our region in improving the health here too. So as I said, we've got a series of events. Some of the events coming up in October, we've got Dr Imtiaz Ahmad from QPRFC. He'll be talking about the role of a football club doctor. And then in March next year, Michael Blackie is a sports dentist. He'll be talking about the sort of trauma or oral health injuries that might occur through sport, but also the importance of oral health in elite sport. And then finally, in April next year, really pleased to be letting you know that we've got Steve Kemp, the lead men's physio for the England football team. Steve will hopefully be speaking at an in-person event about rehabilitation and his role in the England football team. And obviously, it's a critical time in between the Euros and the World Cup taking place at the end of the year next year. So, yeah, that's us and the events that we've got planned. As I said, get in touch with Ollie or myself if there's anything that we can help with. Just leaves me to briefly introduce Dr. Ian Horsley, and just want to say a really big thank you to Ian, as we have done to all of our guest speakers who kindly give up their time. Ian is a very busy person, recently back from Tokyo. I think over 30 years experience in physiotherapy, and hopefully he'll be sharing some of his insights this evening. So yeah, I'm sure it'll be really useful. But thanks, Ian, and thanks everyone for joining.
Okay, right. Thanks for everybody. Just to let you know, what I tend to do when I'm speaking is turn my video off. So you've already seen far too much of me from there. So let me get going. Oh, yeah. Why are we not? Why are you not sharing?
Your slides are up, Ian. You just need to go into presenter mode. So
let me get into. I can't see my slides. Now, why is that then? Aha. Let me get rid of your. That's fine. Too busy looking at your face, Ollie. That's. That's
condolences.
Right. I'll get to present that when we're good to go. Right, everybody. Thank you. Sorry about that. You'd have thought I'd done this a few times before and know what I was doing. So thanks for giving up your evening. And this. And thanks to Andrew and Sarah Plasport giving me the opportunity to talk about my current area of interest. So it's about how we select whether an athlete is ready to go back to play, and that's probably one of the biggest questions that I get asked within my career. So as we can see from the literature here, the prevalence of shoulder injuries in sport goes from sort of very low in cricket to sort of quite high in swimming. But prevalence alone isn't the main concern. It's the severity that we need to think about more, and that's related to the time loss. And that's the most important statistic when you're working within sport. So obviously it'd be better if we could prevent the injury in the first place. So to do this, we ought to think about the risk. And risk is the possibility of something bad happening. It involves uncertainty about the effects and the implications of an activity. And risk needs to be continually assessed throughout the rehab continuum. We talk about risks to injury, okay, about trying to prevent injury, but as we go through that continuum from acute injury to return to play, there at each stage there will be a relative risk to this case to the shoulder. So what sort of things should we be thinking about when we're thinking about risk assessment? So this is a nice but busy slide, and this is the strategic assessment of risk and risk tolerance. And as you can see here, there's sort of three steps in there. And in the first step, this is looking at the health of the tissues. In the second step here, that's the participation risk, and what stresses will the tissues be exposed to, specifically related to the activity. And then thirdly, we've got the risk tolerance or the robustness. But when we look at all these risks, we've got to look at them and see what we can do. We can see that some of these risks are modifiable. Some of them are partly modifiable, and some of them are non-modifiable at all, such as age and previous injury. And a study done from handball by a colleague of mine, Martin Asker, found in his systematic review that there's limited evidence for potential risk factors related to shoulder injury in overhead sports. And on top of that, most were non-modifiable. So what are we going to do? Okay, there's little evidence of what risk factors to consider or what prevention strategy to employ. So the main purpose of screening, in this case for the shoulder in sport, should be to evaluate current shoulder status. And several things have been purported to be useful. So if you look on this slide here, that have been investigated. We've got range of motion deficits, muscle imbalance or weakness. We've got the demographics of the athletes, we've got posture, we've got previous history, and much argued about that funky movement of the scapular dyskinesis. So in sport, what we need to be doing, we need to evaluate the current status of the shoulder and measure improvements in performance to serve as normative values to reach before return to play following injury. And this is very difficult, especially if you're not embedded in a sport, and certainly if you're working in a hospital or private practice where you get a random sports person coming in. It's very, very difficult to know any normative data. So when we're thinking about what tests we ought to be using to screen our athletes and our patients, what they need is a strong relationship to be demonstrated. Okay, so prospective studies should have shown a marker for a screening test and an injury risk. And it needs to be used in validated relevant populations. And once again, that's difficult because even if you look in literature, when you look at most of the data from sport, they tend to be athletic collegiate athletes. They're not, certainly I work in elite sport and there's very little data put out there about elite sports because we're all very secret squirrel about what goes on, and they don't want to give any proposed advantage away by giving information about their athletes. We also need to know that if we use something that it does do what it says on the tin, okay, that it can identify athletes that be in a higher risk than ones who are not at a higher risk. So it's not just do the same for everybody, whether they're at risk or not, and get the same outcome. The other thing, and we get a little bit mixed up with terminology, is we need to make a distinction of what we use the test for. And often the terms functional tests or physical performance tests are used together or synonyms for each other. So if we look at a functional test, that's assessment tools that closely simulate a given sport or activity. So we need to be mimicking the forces and the positions, in this case, that the shoulder works in. Whereas physical performance tests are shown where an activity that represents some aspect of athletic function, such as stability, strength or power, but not the complete movement of that athlete's shoulder. And for us working in less higher echelons, what we should be looking at from a sort of a clinic level, ideally, these need to be easy to perform in the clinic and inexpensive. You look at pieces of kit that are out there that are reported in literature that cost thousands of pounds up to tens of thousands of pounds. They need to demonstrate a good psychometric properties, that they've got good validity and reliability. And then we need some normative data with reliable standard errors of measurement and minimal detectable changes, so we can see whether our interventions are actually having an effect or whether it's just luck. So we need to make those clear distinctions between clinical tests and physical performance tests. And as I sort of mentioned earlier, from the rehabilitation is a continuum, and we can split it into 3 phases to make it a little bit easier. And each phase should have a predetermined entry and exit criteria. So we've got our injury, okay, a bit further on as we're starting to get them functioning a little bit better. We've got a return to participation, and in this case, we start them moving around a little bit more, and they've got some form of protection around the shoulder. Then we can think of return to activity, to return to sport, and again, there is still a little bit of support around the shoulder, but again, if we look here, this is probably giving more proprioceptive input to the shoulder, where the first one is definitely giving a physical block to getting the arm in that vulnerable position of abduction and external rotation. And then finally, that is that return to performance, and that is getting the athlete back to the level and standard of play that they were before they got injured. Often we find that rehab stops here on this return to sport, that players pass the test, that they can go back to playing their sport. Let's say it's tennis. But what you find is that they're not up to the type of performance, they're not serving as fast as they were pre-injury. And that's not because they're injured, it's just that their conditioning's down. So remember, once we got them back, we need to get them to being back as good performing before they got injured. Or we can look at it another way. We can go from constrained training to train, and then returning to training. So what can we do to think of these stages? So there's been some decent suggestions in a nice paper by Wilk et al. in 2020, who said these are return to participation criteria from here. And it's evident what we've got from here. So we certainly need to consider the time from injury or surgical healing, because what we can't do is we can't rush biology. But if we look through here, the ones that are highlighted with the stars, they're just general statements, and how do they help us? So a successful completion of a formal rehabilitation program. What's classed as successful completion, and what is a formal rehabilitation program? Surely if all our athletes are individual people, it needs to be more informal and more personal. Excellent stability with no pain during special tests. One, what are special tests, and how we define what excellent stability is. And bearing in mind that one of the definitions of instability is a symptomatic laxity that can only be told to us by our athletes and patients. And then finally here, a nice generic statement: satisfactory scores on functional tests. One, which functional tests, and how we decide which scores are satisfactory or not. So maybe tonight you were hoping that I was going to answer some of these questions, but I have a confession to make. There's currently no single test battery or batteries of tests that have been evaluated for return to sport after shoulder injury. So we could end it there, or we could try and look at some other things around there and try and come up with another way of sorting it out ourselves. Again, from that same paper by Wilk out here, they've got a few suggestions for our clearance criteria for a return to sport. So we've got the Western Ontario Shoulder Index, which was initially designed as a primary outcome measure for patients with shoulder instability. It's got 5 categories with 27 questions. But the thing I've highlighted most around here is this bit around isokinetics. So we've given some values here, some for external rotator peak torque, body weight ratio, internal rotation peak torque, body weight ratio, and then the internal external rotation ratios. And if we look at the speed that they're testing here, that's at 180 degrees per second. So just bear that in mind. So here are some data about the angular velocity of the shoulder in several sports. And if we look at these sports here, look at the angular speed that they're going at. It's much greater than the 180 degrees per second, okay, that were given by Wilk et al. So we've got to think is, what is the value of that, doing it at 180 degrees per second? Yes, it can give us some data, but how valid is that data? And bearing in mind the phenomenal cost of an isokinetic dynamometer, we've got to think if we can use spend our money better. Having said that, in my clinic, we've got an isokinetic dynamometer, and I can't remember the last time I did an isokinetic test on somebody's shoulder. But even if we are doing a test on somebody's shoulder, this position's not standardized. So here are 3 common positions that the isokinetic internal external rotation strength of the shoulder is measured at. Okay, so again, how does that relate to function of the shoulder in the different sports and what they're doing? We've got to think about it's concentric of the eccentric, concentric. Again, we've got to think about how these muscles of the shoulder are working. And then another thing that we all agree to, that the influence of the kinetic chain on the force produced at the shoulder. we've got 50% of that force comes from the waist down, 30% of that force comes from the trunk, and only 20% comes from locally. And the way we're set up in an isokinetic dynamometer is that you are strapped into isokinetic dynamometer and artificially given this 80% so we can measure what's going on around there. But again, in real life, okay, if we've got leakage of energy through here and leakage of energy through here, we've got a problem. Therefore, we've got to consider a little bit more to consider the kinetic chain. And then don't get me started about strength, the argument about strength. We taught strength is reported in lots of paper, but strength is just not one thing. There are lots of different types of muscle contraction. We've got concentric, eccentric, isometric. We've got plyometric. We've got the angle that we work on. We've got the rate of force development. So just to say we're getting a strength value, how valid is that for us? But there's some things that are out there, and then hopefully this is quite a busy slide. But looking at some of the pre-participation tests here, we can see that the correlations that happen between isokinetic external rotation at 60 degrees per second and isokinetic external rotation at 108 degrees per second, looking at external rotation strength measured with something a lot cheaper with a handheld dynamometry. So at 60 degrees, we can see that there's a strong correlation there that tells us something about muscle recruitment, but is it really telling us about strength here? And what else we've got here? We've got the green ones here, and these are some of the functional performance tests that I'll speak about later, where this is repetitions to failure here, and this is a prone horizontal abduction from there. So we'll introduce these later. So there is some correlation of taking some force measurement around the shoulder that correlates with some of the tests. And how do we measure the force output around the shoulder? So here are some common ways of looking at middle trap, serratus anterior, upper trap, lower trap, okay, internal, external rotation, and internal rotation. And again, some of the handheld dynamometers out there are quite expensive, but recently I've been using this the new on the block. This is the Active Force 2, this little blue thing here that connects to an app on your phone. This has been shown to be very reliable, and this handheld dynamometer costs less than £300. Here are some of the physical performance tests that are currently used out there. There's the ball drop test. There's the wall throw 90-90 test. So again, using a 1 kilogram medicine ball. Okay, we've got the funkily named closed kinetic chain upper extremity stability test. We have got the upper quarter Y balance test. We have got the one arm hop, and we've got the seated medicine ball throw. So again, if we look at these tests and see what evidence says to us, so based on the current evidence, the closed kinetic chain upper extremity stability test, the test with the longest name in the world, the unilateral seated shot, the one arm hop test, and medicine ball throw might have some promise as physical performance tests. So just hold that thought there. But what I like being simple and easy and quick. And one of the things that we found out is the use of grip strength. Grip strength is a magical measure, not only the local system, but it can tell us of general health. It can tell us of nutritional status. It can predict how long somebody will remain in hospital before discharged. And we've done a couple of papers sort of validating this. So we looked at this paper here. So does hand grip strength correlate with shoulder external rotation strength? And we found that it had good to excellent correlation between external rotation strength. We looked at it in three different positions, but all were good to excellent. And then secondly, we looked at a little bit more detail, looking at EMG. So again, can it be used as a surrogate marker to monitor recovery from shoulder injury. And again, we found that it's really, really good at monitoring recovery. And it's quite straightforward how we assess grip strength.
Okay, this is how we want to measure grip strength using the hand grip dynamometer. So if we get the hand grip dynamometer, place it in the subject's hand. Okay, so we make sure that the middle row of the finger joints are around the handle. Turn the hand into mid position. We want 90 degrees elbow flexion, neutral wrist, and then we want our athlete to squeeze as hard as they can for 3 seconds. 2, 1, and relax. And then we record the value. We repeat that 3 times, and then we will normalize that to their body weight.
So it's quite straightforward and simple, but like most things, if you have got a hand grip dynamometer, and again, you can get one of those for less than £100, although not that particular model.
Okay, this.
Another thing that I showed you earlier, this is a prone ball test from here, so we can see what happens here. The ball's a little bit too heavy for Jade there. This is a £2 ball or a 1 kilogram ball, and the number of releases are catches, and we can get some values from here. But the expectation is that the dominant shoulder produces a sort of 110% value compared to the non-dominant. We saw the 90-90 plyo ball against the wall, again, the 1 kilogram or £2 against the ball. Okay, and you look at the ability to do that for 90 seconds and get a baseline and compare left and right. Got the single arm seated shot put test. So again, use a medicine ball. So most of these are in pounds because they were originally described in the US. So here we'd use a 2 kilogram med ball. So here we've got the test, and you push it forward as far as possible, and you measure the distance. Now, this test has some good bits. It's a single arm test. That there is the double arm shot put test, but we want to look at one arm. So yes, I like it because it's a unilateral test, but I don't like it because again, you're sat with your back against the wall, and then that negates the impact of your kinetic chain. And you measure the distance. You hold your arm out in front of you, make a mark there. That's where you will release the ball, and you measure the distance from there to the point where the ball lands. We've got the Y balance, upper quarter Y balance, which is exactly the same as the lower quarter Y balance. So the central arm is the arm where we're testing, and we slide along each arm, measuring the distance in each direction. And then we take the data, we can compare dominant and non-dominant, and we can have a limb symmetry index. And once again, there should be no real difference in that composite score between the left and the right. The one arm hop test, very interesting test here. So if we look at this here, this is hopping on to a 10.2 centimeter steps for 5 reps, and it's timed. Why is it 10.2? Well, it just happens to be the top of the Reebok, old-fashioned Reebok step from there. Now, what do we know about this test? Well, there's a great capacity for injury. So it could go fractured scaphoid, dislocated wrist, dislocated elbow, dislocated shoulder, broken nose, broken teeth, broken jaw. So it's a test you need to use judiciously, again, and it's quite high end from there. So you need to choose your athlete wisely. The closed kinetic chain upper extremity test that we talked about is quite ubiquitous, and here's an explanation.
This is a good part of the screening assessment. This is the closed kinetic chain upper extremity stability test, also known as the Speed-Davis test. So what we need is, for all athletes, are 2 marks on the floor which are 36 inches apart, and then we'll get our athlete to get into press-up position. We need to standardize to make sure they keep their feet together, and then what happens over 15 seconds, they have to alternately touch the marks on the floor.
So you can see it done there. Here are some examples of some athletes doing it. we can see quite slow. See athletes cheat, they need the feet together. We'll move on a little bit. Again, even wider feet to start with. Again, you think the picture better. Again, pretty slow, feet still not together. Feet wide again, and then we've talked about, we started putting the scores up on the wall, and suddenly there's a bit of a change. Then again, wide feet again. So you've got to make sure that you are standardizing that from there, because this is not the test that we want when we've got the feet there, especially when we give them a line to put the feet on. So you've got to be careful and making sure that your test is doing what you want. So again, something that we did a few years ago, we were looking at power in the upper limb. And so one of our MSc student and current physios at the Institute, Gemma Parry, came in for boxing for a year, and we developed this counter movement push-up test. So using two individual force plates, we get them just to do like a normal counter movement jump you do in the lower limb, but as a press up. So here we can see the difference. Okay, so you'll say it's quite obvious which one's more powerful without having the having all the force plates there. There you go, pretty obvious from there. And then the research came to show us when we looked at the test reliability from there, and the conclusion was that the upper limb power output in elite boxers can be reliably assessed using a force plate, and that unilateral data can be reliably extrapolated from bilateral conditions. So that's a nice thing to do, but once again, that's using force plates a little bit. But having said that, some of the jump mats are getting more cheap to buy. And this has been around, colleague of mine, Ben Ashworth, for a while. The ASH test that everybody's talking about here, the initial test again used force plates, where you test the force produced by the shoulder in that I, Y, and T position. But here, just using their little active force here to get a measure. So in that I position there, so you go and press. And then go again and press in that Y position, and then finally in that T position. As you can see, it's a reliable test. Okay, but exactly what it's a reliable test of, Ben's doing some more work on that. So here we've got the posterior shoulder endurance test. So looking at the back of the shoulder, which we tend not to work out. So again, this is set up, use a metronome that's set at 30 beats per minute, and the weight that is selected is at is 2% of the body weight. But once again, it was done in America, so it's to the nearest pound. So we do it to the nearest ½ kilogram.
Endurance test, and this is the dynamic in the original version of the posterior shoulder endurance test. So what we need with this is you need a metronome. So any metronome app will do, and you set your metronome app to 60 beats per minute, and then we're going to take a second up and a second down. So the idea is that we take a weight that is 2% of the athlete's body weight to the nearest kilogram that we can manage, and the idea is then from the to abduct to 90 degrees abduction with external rotation. So we'll put a marker there for them to hit, and carry on repping out in time with the metronome until they fatigue or they start to fail. So we start off again. Here we go.
So when we've used this, and we repeated this test, we contacted the original authors because our values with elite athletes were much lower than the values that they published in their paper. And when we discussed with the lead author from there, it was decided that we were so much more strict in what classified a failure than they did. And then more recently, they modified this test to make it an isometric test. So you just hold the arm in that position. So that cuts out some of the error in scoring. But again, you've got to think about, is that functional just to do an isometric test rather than a dynamic test? But as it stands, return to sport can't be determined by one specific test. So we need to use a battery of tests, but also we need to use our clinical reasoning. So we need to choose our tests and our consideration for using that test that need to be athlete and sport specific. Then we have our test result, whether they pass or fail. If they pass, then we can progress for load or stability or repetition to fatigue. But more importantly, if they fail, is to understand why they fail and which part of their rehabilitation program do we have to work on. Now, more recently, a colleague down in New Zealand, Margiold, talked about the reliability of the shoulder arm return to sport battery of tests, which is basically 4 open kinetic chain tests and 4 closed kinetic chains tests. So here are the videos here. So first one.
Being a 3 kilogram dumbbell or suitable weighted ball. Okay, we go from out, elbow out straight, back, up over the head, and down, and then out, back, up.
So all these tests are carried out for 1 minute.
Take your tennis ball out to 90 degrees, elbow 90 degrees, and drop and catch, drop and catch, drop and catch, drop and catch, drop and catch.
Again for 1 minute. And here this is a 5 kilogram dumbbell, medicine ball.
So down, reach up above your head, down, squat, and up. And then
again for 1 minute, and then finally using a Swiss ball, we get that 90-90 bounce against the wall for a minute. And as you can see here, that Beth's struggling quite a bit. So we're not at that 90-90 position. That elbow needs to be higher, and we're not getting internal external rotation. We're getting flexion extension. So again, that attention to detail is important. Then they closed kinetic chain tests a little bit more strenuous. So here we have got a plyo press up. Okay, from there. So plyo with a clap. Okay, and even I'm struggling to do it because I'm not the most strong in the upper limb. Okay.
Side arm up to ceiling. Good.
And we've got a sort of threading the needle going through again. Done for a minute. We've got the closed kinetic chain upper extremity stability test.
Alternate hands touch and back in each time. Back to.
And then finally, we got the 1 arm hop test. Okay, again for a side from there. And we need to make sure that the hip's not in flexion. That we've got a long lever there. But as you can see here, they are quite challenging. So you have to choose your athlete suitably. Then again, another test has been a sort of a raft towards the end of last year, beginning of this year. So we have got this nice little test from the sort of Belgium or so ankles or around there, which is this upper limb rotational test here.
Position.
So set into plank position and then up to touch the elbow on that marker on the wall. So you count the number of touches, successful test in 15 seconds, rest for 45 seconds and then repeat again. So you do 3 15 seconds tests with 45 seconds in between. And then finally, very recently from their group, so Phil DeCleve has come up with their shoulder endurance test. Again, using a metronome, so this is 60 beats a minute for 20 seconds. Again, elbow's got to hit the mark on the wall. 90 beats for 20 seconds, 120 beats for 20 seconds. Okay, and 150 beats until you are knackered from there. So again, there's some normative data got to come from that. But again, we've got to think about how that could look a little bit more functional for overhead tasks. So we know that our functional tests and our physical performance tests, what they've got to do. But more importantly, we need to think about what does our shoulder have to do? We need to know, is our athlete standing, sitting or lying down? Are they operating? Are they using their shoulder mainly above the shoulder line, below the shoulder? Is it a unilateral or a bilateral activity? Do they need trunk rotation? Yes or no? And does it need to be symmetrical? And then from their sort of physiological characteristic, do they need a high strength, a high rate of force development, so powerful, high endurance, or high speed? So we've got to know that about our athletes. And then we've got to think about, what reported outcomes can we use. So again, currently there are no really good reported outcome for sport from there. This is sort of a relatively new kid on the blocks. These are the ones that we tend to use in clinic. Okay, but the Curler-Jobe Orthopedic Clinic score has been shown to have some value. It's been designed to look at the elbow and shoulder in baseball, but it's been modified for use in other sports. And this year we brought out a paper looking at its value in canoeing. And if we look here, we can see how the questions relate specifically to the sport that you're doing, which makes it really, really valid from there. So you score between 0 and 10 for the paper. So again, we've got to think about what is our shoulder doing. And once we've thought about what is our shoulder doing, and whereabouts is it operating in, let's look at what happens in some sports. So what I did, I contacted some of the lead physios in these sports, and I asked them, the simple question is to roughly classify how much of the sport the shoulder is above the shoulder, in line with the shoulder, or below the shoulder. And so if we look here at these sports in red, badminton over 50% is above the shoulder, swimming 55% above the shoulder, cricket 100% when you're bowling above the shoulder, and gymnastics anything between 20 and 100% from there. So if we think about that, and if we think about some of the other sports, we can see that a vast majority of our sports use their shoulder in an overhead position. So one of the current pieces of work that I'm working on, and we're just doing some collaborating with a Belgian group, talk at this in a little bit more detail. Here is a breakdown of some of the main tests that we use from there. So we're looking at this test, classify, is it a bilateral test, a unilateral test? Does it involve the kinetic chain or not? And is it an open kinetic chain exercise, a closed kinetic chain exercise? And then this strength component, so not just about strength, does it require the sport? Does it require a high force? Does it require a high rate of force development? Does it require high endurance? Does it require high speed? And is there an eccentric component from there? So that's what we need to think a little bit more about when we're selecting a return to participation, a return to play sport, is what parameters will it test? So let's try and give you an example here. So our context, so let's take boxing. And what I was told is 10% above the shoulder, but 70% in line with shoulder. So what tests have we got around there? So we can look at the ones where it's in line with the shoulder. So one arm hop test, the upper quarter wide balance, the single arm shot put test, and the close kinetic chain upper extremity stability test could all be valid relating to what's going on here. So again, we've got to think about how our tests relate to the functionality of that sport. So our general considerations for our return to play would be, we've got to think about the pain. Obviously, we don't want any pain as an athlete returns to sport, because that can inhibit muscle function. We need the active range of motion, which is crucial for that sport. So again, knowing what that range is and whether it needs to be symmetrical or not. And again, the generalized term strength. All sports have a demand of the shoulder strength, which is sport specific. So again, we've got to consider all those 5 components of that strength, force production, whatever you want to call it from there. And certainly we need to think about the kinetic chain and how that's optimized. So that's the straightforward stuff. And then just to round everything off, other things we need to consider for a successful outcome is what we're talking about now, our psychosocial thing. They are a person, not just an athletic machine. So we need to take all these outcomes and behaviors into consideration. And again, this psychological aspect. So we can see here that even 2 months post this injury, 53% of injured athletes have significant higher levels of depression, anxiety, and lower self-esteem than they're non-injured and fully recovered. So again, we need to look at that. So we need to use some sort of markers. Okay, and again, lack of confidence as injured body part also can lead to further and repeated injury. We need to think about that fear of movement. And so using the Tampa scale of kinesiophobia is quite easy. It's a self-reported questionnaire. So 17 items from there. So another thing you can give your athlete towards the end. And then finally, which I use quite a lot, is this injury psychological readiness to return to sport scale, which gives us a nice overall confidence return to play despite our best efforts. So sometimes you can rehab a patient, do all the testing and be back to pre-injured levels. But when we go through the IPRRS, okay, we find that it's below, okay, that's 60. So we want something greater than 60 really on this score from 0 to 100 so that they are mentally ready. And then if we think about other things that, again, while we're being holistic, these social determinants of health, and it's something we talk about the biopsychosocial, but really, okay, do we really think about the social things? And these things like where people live, their race, ethnicity, gender, occupation, and their socioeconomic status all have a big influence. In fact, research tells us that the social determinants of health have the biggest influence on health, morbidity, and mortality, greater than an influence of the outcomes, greater than genetics. Okay, so when we're looking at the biopsychosocial model, okay, do we really think about the social? We're very all into the psycho now at the exclusion of bio to some degrees. We've got to consider all parts. So here we are, my summary of what I think is we need to know the sport. You need to know the functional requirement of the shoulder for that sport. You need to select a physical performance test that matches the components, so the range and force of that sport. You need to know the normative values for that sport. You need to know the reliability, and you need to remember that they are a person. And then finally, if you really do are interested in shoulder, in February next year, this is going to be the new shoulder Bible. So some of the great and good people within the world of shoulder rehabilitation, and for some reason I managed to sneak into there as well, have written chapters covering all aspects of the shoulder. And as you can see there, if you register early now, you'll get 10% off. So I think it's going to be about £70 to begin with. So that's me. I hope it's been useful. I've not done bad. I said I'd do it in 45 minutes, and that's about 45 minutes. There's been a lot there I've thrown at you, so hopefully you'll get to be able to watch it again. And if you've got any questions, feel free to get in touch with me. So thank you. So any questions, just shout up.
Brilliant. Thanks, Ian. Some really valuable info in there. So if you would like to ask Ian a question, just put your questions in the Q&A box. We haven't got any through at the moment, I don't think. Someone has asked, where can we view this presentation again? I think this is going to be popped on the Bazarat YouTube, I believe.
Yeah, it'll be, we've got the recording. It'll go up on the YouTube tomorrow, so everyone can revisit, because there's tons of information there, which is phenomenal, but I think it's a lot to digest. You did really well getting it into the 40 minutes, by the way.
I was looking at the clock in front of me. Started to gabble a bit towards the end. Yeah.
We'll give people a couple of minutes to post any questions if they've got them. If not, then we'll invite people to send them over to you on Twitter and email. Would you mind, Ian, have you closed your presentation, or can you pop those contact details back up?
Yeah, I shall. Let me go back up there. Share screen.
Brilliant. Well, we've got one coming into the chat. Cool. There we go. Some coming in now, Serena.
Yeah. So someone's asked, Ian, is there a certain time during return to play to include specific tests?
As I said, it is that continuum. So, if you take an example that I showed you there, that one arm hop test, that's definitely end stage. Okay, you wouldn't be doing that in an intermediate stage because there are forces that go through there. So again, we've got various tests that put various loads in certain positions of our range. So again, that's why you have got to be aware and cognizant as you're going through there of where you are on that rehab continuum, that tissue healing continuum, because the thing we don't want to be doing, we don't want to be breaking our athletes as we're rehabilitating them. And sometimes in our sort of enthusiasm to get them better quicker, we can start doing some tests which are a little bit too much for them. That's why it's important to predetermine your entry and exit criteria for each person, whether that be a range of motion or whether it be a percentage of injured strength. So there's a lot of thinking, and it's exact for the individual. And it's very hard if you don't work within a sport because you don't have all these data. So it's just thinking, okay, I'm being critical, really.
Yeah. Someone's asked, currently working with a rugby 7 semi-pro player, positive sulcus sign and current instability. Regarding return to play, would you advise ISO strength for elite rugby players test?
Okay, so the big thing about somebody who's got a sulcus sign, and again, you have to check out the rest of their body to see whether they are generally hypermobile. But if somebody's got a laxity around the joint, then the big thing is that changes their proprioception. And we know it's that proprioception and that feed forward mechanism that it gives to the cuff to stabilize the joint. So again, it's not about strengthening, it's about engaging the muscles and getting them firing at the right time, which is a good question because I was asked if I could put an anecdote in from Tokyo. So during Tokyo, we had one of the rugby sevens players who dislocated his shoulder basically in the last tackle of the group game, and they were due to play in the bronze medal game, and we had a look at him. We had him scanned, and in the time we were waiting for his scan results to come back, we used a neurological rehabilitation program and a strategy to manage him. And by the end of the day, we'd got full pain-free function of his shoulder. We got his scan result at the end of the day that said he had some structural damage around his shoulder. We discussed it with the player, with the doctor, and with the whole medical team, and they decided on the next morning to put him through a return to play contact testing with his shoulder. He got through that, and he played in the bronze medal playoff game. So again, it's so important about getting that neurological stimulus right. We didn't do anything to do with strength at all. It was just about getting recruitment right around his shoulder. It's subsequently gone on since he's come back to have some surgery because it was decided that was the best thing. But at least we got him in with a chance of safely playing in a match where he could have got a bronze medal. Unfortunately, it wasn't to be, and they came fourth.
Yeah, brilliant. I think you've answered this, Ian, but someone said, do you think so-called special tests are particularly useful or accurate?
It's one of those things, though. You ask special tests, what is so special about them? They're just tests for another name, and there's been oodles written about them. That what a majority of them are pain provocative tests.
Yeah.
We don't know really what's causing the pain, and we state that if we do it this way, it's this tissue, and if we do it that way, it's another tissue. Having said that, I do use some special tests in my when I'm doing examination, but I use the same examination all the time, and so it's related to pattern recognition. So it's not them as standalone tests for what they supposedly, whether it's be supraspinatus or whether it be labrum or whatever. They fit in a battery of my examination, as I say, and tend to fit with the millions of years of experience that I've had. That you can see patterns developing, and that's what helps me make my decisions.
Yeah. Last question for now, Ian. Would a wall push work with the inline tests and give best results, or is it now old school?
Just say again, sorry, I just mixed up perfect.
Would a wall push work?
Yeah, so again, a wall push is fine. We've got less load from there. So again, it would be a way of mitigating some of these tests. So doing a wall push, okay, you've got less body weight through there. You can stand vertical against the wall, and as your body comes incline, there'll be more force going through your shoulder until you get to that position. So again, that's one way of you go through your testing. You can mitigate that load and make the decision about where you are on that return to play continuum.
Yeah, we've actually got one last question, Ian. Sorry, it's quite a good question. What neuro rehabilitation program did you use with your rugby player? How does it differ from the tests you've already spoken about?
So a lot of it, again, and it's a really good question. It's another area that I'm sort of into at the moment. So basically what our brains are threat detectors. Okay, they send messages out and receive messages a little bit like an echo. And when they send a message out, they expect the message to come back in a certain way. And if it comes back in a certain way, then we're happy. If that message comes back a little bit differently, then that's perceived as a threat. And then what that means is the next message that the brain throws out is different, and therefore the message back is different. So it's about optimizing movement, down regulating the threat, working on quality of movement, and doing a lot of talking with their player, and there's some really clever techniques which are weird, which involve you doing stuff with your tongue, doing stuff with your eyes that getting into your cranial nerves that then can influence how your shoulder works. So it was quite insightful really, and the rest of the staff were watching and thought I was just doing a spoof video, because some of the things that were getting the player to do with his eyes and with his tongue to change his range worked. And once they can see that they move without pain, that de-escalates the threat level in the brain, and the outputs matches. So the input starts to match the output, and once we normalize that, we can start to get normal patterns. But that's the way now. It's all about training the brain.
The brain. Fab. I think we'll wrap up there. Right. Thank you very much, Ian.
Okay, no, thank you again for the opportunity, but feel free, if you think of anything else, to contact me. That's why my details are there.
Brilliant.
Can we just bring Andrew back in as well, just as we're wrapping up? I don't know if he's ready. There he is.
Yeah, thanks, Ian. Really good presentation. It's always, I think we're sort of getting a good theme now from the quality of speakers that we've got, that I think the message to people that are working in sports rehab is, take an evidence-based approach, develop your own systems, and you're saying you've got your own battery of tests, and it's about sort of validating things and having quality in your work so that you can have confidence in what you're doing. But it was really interesting to see how you apply the evidence in a really practical way, and the importance of the psychological and social stuff is fascinating as well. And I think there's obviously a lot more to be done in those areas. But thanks very much. Thanks, Serena, for comparing and the good questions, and thanks, Ollie, as always. Thanks very much, everyone, for joining, and we'll hopefully catch you all soon.
Yeah. All right, thanks everybody.
Thanks everyone.
Okay, see you all. Take care. Bye-bye.